Good afternoon, students. I want to welcome you once more to Fitness and Technology workshop. This week we are going to look at cardiovascular diseases. What means and technologies are appropriate for cardiovascular diseases? Firstly, I want to give you an introduction. Among the top 10 causes of death globally, ischemic heart diseases cut us for 24%, stroke and other cardiovascular diseases cut us for 21%, and these rank the top 2 among the 10 causes of death. And if you look at the top 10 causes of death among high-income countries, again you find that ischemic heart disease and stroke and other cardiovascular diseases rank the top 2. We have an additional disease, which is hypertension, hypertensive heart disease, which is about 4%. This basically indicates that heart diseases are one of the top death-causing diseases and are very important, especially in high-income countries. Firstly, let's look at the stats. In Australia, the mortality in Australia in 2009, 7% of the deaths in Australia were due to cardiovascular disease. And currently, 2018, about 1 person dies in every 12 to 15 minutes as a result of heart disease in Australia. So this basically shows the seriousness of this disease burden. Ischemic heart disease cut us for 16%, which includes angina, blocked arteries of the heart, and myocardial infarction. We'll talk more about this. And also includes stroke. Stroke basically is a result of hemorrhagic and ischemic heart problem, which cut us for 80% of these deaths. And then we have heart failure, deaths as a result of heart failure, hypertension disease, and arrhythmias. These they cut us for 10.7% of Australian deaths. So I pick out Australia because it's one of the high-income countries. They have valuable statistical data. And if you look at the risk factors for cardiovascular disease, risk factors mean the factors that will help into manifestation of heart failure or heart disease. Basically, these include age, age, especially in older age, people with older age of 60s, 70s and upwards are predisposed to heart problems. Male, sex, meaning if you're male, you have a higher risk of cardiovascular disease. Diabetes, current smokers, people that are currently smoking, are higher risk. And also if the mean blood pressure, say 20 millimeter mercury, if the mean blood pressure is high, that also possibly to the vesicle. Also, cholesterol levels play a huge role. We'll talk more about this. And body mass index. The body mass index basically is an indicator for the obesity and overweight. For example, if you are overweight, that's an indicator that is there. You can see whatever the rates, the ratio rates there are above 1. Any ratio rate above 1 indicates severe risk. But for good, ratio rates must be below 1. So let's look at the adverse cardiovascular conditions, which means these are conditions that can lead to death. First, we have atherosclerosis, followed by hypertension. Those are marked in green because they are one of the top contributors to death. Followed by that, cardiac arrhythmias, congestive heart failure, valvular heart disease, also congenital and infectious causes of heart disease. Let's look at atherosclerosis and cholesterol. Basically, atherosclerosis is where a plaque, also called atheroma, occurs in an artery. This is a blockade in the blood arteries, which prevents blood from flowing to the heart, specifically to the heart, because the heart is the engine of the body and it pumps the blood to the rest of the body. If the heart is not receiving adequate blood, the oxygen requirements for the blood, for the heart, is highly reduced and it impairs the heart function. Also, cholesterol is considered to be one of the principal causes of atheroma, because cholesterol builds up in the blood arteries, specifically the bad cholesterol, because there is good cholesterol and bad cholesterol. I'll talk more about this. Cholesterol, however, is essential for the human body. So the good cholesterol is essential, as we are going to talk about. Let's talk about a condition called hyperlipidemia. Hyperlipidemia basically is a condition where there is high level of lipids or fat accumulation in the blood, especially in the blood. Yes. Now, it's important to understand that blood levels above the desirable can lead to heart disease. When you have higher levels of fat in the blood above a certain level, can lead to heart disease. This is even more significant with, for example, certain family history. We know certain families are predisposed to obesity, for example, or to hyperlipidemia because of their maybe feeding habits and their genetics. And sometimes such related factors. Also, people with hypertension, high blood pressure, people who are obese, those who are smoking, those who have glucose intolerance and renal impairment. These are highly affected by such heart problems. Now, below is the table that shows the levels, the standard levels of each of the lipid components in blood. Firstly, on top there we have LDL. Basically, stands for low density lipoprotein C, and in the blood, basically, it must be below 2.5 millimolar per liter. If that is below 2.5 millimolar, which indicates that person is in good health. And then for LDL-C actually is the bad form of cholesterol. The low density lipoprotein is a bad form of cholesterol. And we have the HDL-C, which represents high density lipoprotein. This is the good cholesterol, which is beneficial to the body. This one must be above 1 millimolar per liter of blood. Now, the total cholesterol, if you calculate it and count the total cholesterol, must be below 4 millimolar per liter for a good and healthy person. Triglycerides levels should be below 2 millimolar per liter of blood. So basically, these are standards for lipids in blood. Now, let's look closely at atherosclerosis. What is atherosclerosis? Basically, atherosclerosis is a chronic inflammatory response in the walls of arteries. Chronic, how? Basically, it's an accumulation of lipid, cholesterol, collagen, and monocytes. And as these build up inside the arteries, they block the artery, they reduce the artery size and block the flow of blood. Now, atherosclerosis is promoted by low density lipoprotein, which carry cholesterol and triglycerides. As I said earlier, low density lipoprotein is a bad protein. Is a bad cholesterol. So what happens is that with low density lipoprotein, it enhances the buildup of collagen, monocytes, and cholesterol and other lipids within arteries. Usually, atherosclerosis is asymptomatic until catastrophic blockage occurs, meaning that when it's at a low level, any person who is experiencing that will have no symptoms, will notice nothing wrong with himself or herself until such a time when there's extreme blockage or catastrophic blockage of the arteries, which is results into heart problem. So it's a very bad state. Now, here's a diagram basically showing the different levels, the different components of lipids in blood. So you have the HDL cholesterol, which carries cholesterol to liver for metabolism. So you know one of the functions of good cholesterol is that it carries cholesterol to the liver for metabolism. And the LDL cholesterol, which contributes to the buildup of blood and leading to atherosclerosis. So you can see in the diagram, basically you have all sorts of components, including cholesterol, which is represented as a waxy fat carried through the bloodstream by lipoprotein, which is the waxy. There's an insert box there, a rectangular box indicating the yellow part of the component in the blood vessels is cholesterol. And so let's look at the types of hyperlipidemia. There are several types of hyperlipidemia. In fact, to be specific, there are 6 types of lipidemic conditions. The 3 most common ones are type 2A, which is characterized by high cholesterol and high LDL-C cholesterol. So we have such kind of high cholesterol and LDL-C indicates type 2A. And then we have type 2B, which shows a high VLDL and LDL-C. I'll explain this. VLDL basically meaning very low density lipoprotein, which means it's even a worse condition when you have worse type of cholesterol. Then the type 3, which is type 4, which is high high VLDL and hypertriglyceridemia. So this type 4 is characterized by high VLDL and hyper means high level of triglycerides in the blood. Okay, so how does atherosclerosis, how is it presented in the body in any patient? What are the clinical symptoms of a patient who is suffering from or who is having atherosclerosis? Usually, this is is presented as, or is indicated as angina pectoris. When you have atherosclerosis, it's presented as angina pectoris, and the symptoms basically as follows. Firstly, you have what is called chest pain, which is associated with myocardial ischemia. Chest pains usually, which is very, it's characterized by discomfort of the chest. This is where oxygen supply is less than heart muscle demand because of restricted oxygen supply to the heart. And also it's important to know that you get unstable angina as well. So in this slide, you have two pictures. On the left showing the left normal coronary arteries of the heart. So these are blood vessels of the heart, coronary blood vessels of the heart. On the right side of this picture, there's an arrow there indicating a place where there's a blockade, a disjoint, there's no supply of blood, indicating there's an atherosclerosis blockade. So, what are the drugs? What drug therapy are available for hyperlipidemia patients? Firstly, there are drugs called vibrates. Vibrates, the mechanism of action of vibrates is to increase lipolysis in the tissue. Lipolysis basically is the breaking down of lipids in muscles or tissues of the body. And then we also have the second types of drugs, which is nicotinic acid. Nicotinic acid basically, when taken at high doses, it lowers triglyceride levels and it decreases very low density lipoprotein synthesis. So it reduces the production of VLDL. And then also we have another set of drugs called acipimox. Acipimox is a derivative of nicotinic acid. These basically they reduce lipolysis and increase catabolism of VLDL. And the fourth drugs, we can call them drugs, is fish oil. You all know fish oil. Fish oil basically contains high unsaturated fatty acids, also called omega-3 fatty acids. These have anti-hyperlipidemic effects, meaning that they reduce the lipid accumulation in the body. Okay, now let's look at hypercholesterolemia. Hypercholesterolemia is a condition where you have high cholesterol in the blood, and they are drugs specifically for reducing, for treating cholesterol, high cholesterol in the blood. These are called statins. Statins inhibit enzyme, which is HMB-CoA reductase, therefore reducing plasma cholesterol levels. So on the right side, you see biosynthetic pathway of cholesterol. And there's an arrow, upper arrow there, indicating where these statins basically, statins are inhibitors. They inhibit this HMG-CoA reductase. It's a key and a determining enzyme for this pathway. So once they block that enzyme, the buildup of cholesterol is inhibited. So inhibition reduces cholesterol, particularly LDL cholesterol, having little effect on HDL cholesterol, meaning that the blocking of reductase, this HMG-CoA reductase, affects only the low density lipoprotein cholesterol. So which means that the good cholesterol production is not affected. Also, statins have an antiplatelet and anti-inflammatory effects, meaning they will affect blood clotting as well. Okay, so let's look at more about statins. There are examples of these drugs. We have simvastatin, which is very common in South Africa, and atorvastatin, pravastatin, fluvastatin, rosuvastatin. These are drugs that are designed for treatment for people with high cholesterol. Also called HMG-CoA reductase inhibitors. So, simvastatin, atorvastatin, rosuvastatin are in the top 10 drugs in Australia. So by prescription numbers and by total cost. So which means that those are the most common drugs that are used in Australia. And as you know, Australia is known to be an obese nation. Obesity levels are very high. And so when we have drugs like this, which are highly recommended, is a good indicator that the efficacy probably is quite good. Now, this can be supported by a study that was conducted in Scandinavia, so-called S4 study, Scandinavian Simvastatin Survival Study, which involved 4,444 patients with a history of angina or myocardial infarction and who had cholesterol levels of more than 5.5 millimolar per liter, and of the ages between 35 to 70 years, and in a randomized control to simvastatin or placebo. So placebo basically here is a dummy drug, which means it's a pill which has no active ingredient, so has no effect at all. And in this study, the outcome basically is that it was for the duration of 4.5 years follow-up, and for simvastatin treatment, there was a total cholesterol reduction of 25% of the LDL cholesterol, and reduction of 35% of the 25% reduction in the total cholesterol, 35% reduction in the LDL cholesterol, and there was an increase of 8% of the HDL cholesterol, which is a good cholesterol. So such a good result. It's quite encouraging. However, the death rates, there were deaths encountered. 256 patients died, which is 12% of the total population, and then so out of all those who died, in fact, 12% were patients with a placebo. Remember, I said placebo is a dummy drug, which means they did not take any simvastatin treatment. And 182 patients, representing 80% of the population, those who died, were with simvastatin treatment. Okay. Now, it's also important to understand in this study that the relative risk of death in the simvastatin group was 0.7. So, meaning that the risk was very low. Because any risk rate below 1 is low, and anything above 1 is high. Okay. Anyway, there were adverse effects experienced during this trial. 6% in each group discontinued because of adverse effects. So, and one patient, for example, taking simvastatin developed rhabdomyolysis and 6 had creatine kinase more than 10 times upper normal. Okay, rhabdomyolysis basically is the degeneration of skeletal muscles. So the degeneration of skeletal muscles. And creatine is an enzyme that is important for the function of the body, especially for the function of biochemical reactions in the body. A higher rate of creatine kinase is an indication that there's something wrong with the muscles. So 10 times higher of the normal rate indicates that really in these patients there were some physiological problems. Yeah, they probably were sick with certain sicknesses. Okay, let's look at aspirin. Aspirin also has been known to reduce heart rate or to have beneficial effects on cardiovascular disease. It is extracted from a willow plant, the bark of a willow plant. This has been used medicinally for over 4,000 years, since 4,000 years ago, and traditionally and currently is used as an analgesic, meaning it's used as a painkiller, and also is used to reduce fever. For example, if you take 300 to 1,000 milligrams up to 4 times a day, it reduces fever. So, these are some of the aspects of aspirin. It has been found to have antiplatelet activity and began to be used in low dose to prevent cardiovascular events, usually at the rate of 100 milligrams per day. It's known to prevent heart problems. Also, it's thought to have anti-inflammatory effects in cardiovascular diseases. Recently, a low dose was found to prevent cancer, except for stomach cancer. So, let's look at the mechanism of action of aspirin in cardiovascular diseases. Aspirin is a drug, one of the drugs called NSAID, representing non-steroidal anti-inflammatory drug. It reacts with the COX enzyme and irreversibly inhibits it. COX enzyme basically is an enzyme that catalyzes the production of prostaglandin. And these prostaglandins are involved in the stomach mucosa. There are different types of prostaglandins. So there's COX-1 and COX-2 enzymes. So COX-1 is involved in the physiological stimuli. COX-2 is responsible for injury, infection, and inflammatory stimulation. Then the inhibition of COX-1 inhibits the formation of prostaglandin 2, which inhibits platelet coagulation. So, and then inhibition of COX-2 enzyme inhibits formation of prostaglandin 4, which reduces inflammation. Okay. Now, this kind of effect of aspirin also has adverse effects. For example, action on COX-1 also involves inhibition of prostaglandin 1 formation. and prostaglandin 1 formation. Prostaglandin 1 protects the gastric mucosa, which means the lining of the stomach and the intestine. Which means if you block such kind of enzyme, the gastric mucosa will suffer. There's a risk of gastric ulcers and hemorrhage. It's important to know about these side effects. Okay, let's look at the efficacy and safety of aspirin in secondary cardiovascular prevention. So here basically we'll look at the events of cardiovascular disease events and the risk ratios and the numbers. We have non-fatal myocardial infarction. We have cardiac hypertension disease, mortality, and we have ischemic stroke, hemorrhagic stroke, vascular death, and major extracranial bleeding. If you look at the rate ratio, the risk rate ratios here, you can see that among all these, only hemorrhagic stroke has higher risk ratio of 1.6, and more major extracranial bleeding 2.69, meaning that when you take aspirin, the risk for adverse effects in patients that are suffering hemorrhagic stroke are high. Hemorrhagic stroke and major extracranial bleeding are high. So it's important that when you administer aspirin, you need to be very careful for patients that are going through for hemorrhagic stroke and major cranial bleeding that may actually lead to death of patients. Okay, let's look at another study called aspirin. Aspirin standing for aspirin in reducing events in the elderly. So this is a randomized controlled trial of 20,500 healthy people aged more than 70 years. 17,000 of these actually came from Australia. It is a randomized to aspirin 100 mg or placebo daily for 5 years. The question was, will the benefits outweigh the risks? Will the benefits of aspirin outweigh the risks? Let's look at the benefits of aspirin. So these benefits include decreasing the risk of vascular disease, such as heart attack, ischemic stroke, also cognitive decline, and some cancers, reducing cancers. However, there are risks of using aspirin. These are as follows. You have increased risk of GI ulcers, which is gastrointestinal ulcers, hemorrhage, anemia from awkward bleeding, and stomach cancer. So these are some of the adverse effects that you need to be on the lookout for when you are treating patients with aspirin. Okay, now what kind of therapies are available for such kind of heart problems? Firstly is what we call coronary angioplasty, percutaneous transluminal coronary angioplasty. Okay, so percutaneous transluminal coronary angioplasty is one of the methods or therapies for coronary angioplasty. Basically, in this therapy, a thin catheter is gilded or inserted into a coronary artery blockade. Where the coronary artery is blocked, a thin catheter is inserted, and a small balloon at its tip in there is then inflated, which means increasing inflating the balloon also inflates the catheter, increases the catheter, and deflating the balloon up the coronary artery blockade, and after that the balloon catheter is then removed, which means the catheter remains in that position, opening the artery at the point of blockade, opening the artery, allowing the blood to flow. So we also have what we call coronary stenting. Coronary stenting basically involves expanding a metal mesh tube within the artery to hold the artery open at the point where narrowing occurs. As you can see in the diagram there, basically a stent has been inserted. A stent basically is similar to a catheter, where basically it opens up the blockade area to allow blood to flow. It is routinely used in the management of patients with angina or myocardial infarction. Okay, now just to explain how the stent deployment and results. Basically, the stent, as you can see in the first on the left, in the first drawing, stent is inserted in the region of the artery where the plaque is. So we have the catheter with a contracted stent, and followed in the middle there the catheter with expanded stent. So the catheter is expanded stent. After that, we have an open coronary artery. Basically, the balloon is removed and leaving the artery open. Then we also have surgical management options. The first one is what we call coronary artery bypass grafting. Basically, this type of surgery can only happen when we have two principal indications. When we have two principal indications, that means that firstly the patient must have symptoms meaning that firstly when the condition of the patient, symptoms in the patient remain, where despite the optimal medical therapy, which means that the patient who has undergone medical therapy but symptoms are still remaining, qualify for such kind of surgery. Also, patients whose disease is not suitable for PTA, percutaneous therapy. So these are types of conditions or indications for CABG. It's important to note this. It's not a surgical management done for any type of patient, but it must be patients that are in extreme conditions, extreme levels of the disease where other therapies have failed. And also it is used where improved survival in patients with severe 3-vessel CAD are likely. So this is where, for example, the three arteries are blocked at one given time. That's extreme. So you need surgical management. In the picture on the right, you can see a heart with arteries that got vein bypass. There's firstly there are plaques blockade where it's indicated with the arrow, and then you have artery bypass from the aorta, bypassing the plaque blockade area, and also you have another one on the right side, the internal mammalian artery, that from the chest. That also, so basically it shows that areas in which these bypasses can be done. Now let's look at drug treatment. We have peripheral vasodilators as one of the options for treating heart problems. We have what we call nitrates. For example, absorbed nitrates are converted to nitric acid. Nitric acid, once converted, it causes vasodilation. It dilates the blood vessels. Once the blood vessels are dilated, it relieves the blood pressure on the vessels. For example, these drugs are glycerol nitrate and isosorbide dinitrate. These two drugs are called vasodilators. The nitrates which increase vasodilation. We also have another set of drugs called beta blockers. These drugs are used prophylactically, meaning they are used for prevention rather than treatment. Beta blockers, they reduce heart rate and force of contraction on the heart. So basically, beta blockers will reduce the heart rate, resulting in negative chronotropic effect, and the force of ventricular contraction, resulting in negative inotropic effect, both of which reduce myocardial oxygen demand, especially on exertion. So, because heart muscles, as they pump, they require a lot of oxygen. But if you reduce the heart rate, meaning that you also reduce the oxygen demand, and hence you control the heart rate. The next the next drug groups is called calcium channel blockers. The examples of such drugs are amlodipine, budiacept, and the hexaline. Basically, the calcium channel blockers, they dilate coronary arteries, espousing and reduce the force of contraction in the heart. Okay, so these are highly specific on the coronary arteries. And it's important that when you use such kind of drugs, avoid abrupt withdrawal of treatment. Can have these effects. So let's look at blood pressure, because blood pressure is very important in heart problems. How is blood pressure controlled? Because if you know how it is controlled, then we can know how to treat it, or know how the drugs work in such kind of. So basically, blood pressure is regulated by the nervous system. There are receptors in the vasomotor section and the medulla, which adjust blood pressure. So there's a renin-angiotensin system which regulates renal blood flow, which means it regulates the blood flow in the kidneys. And then we have hormones also, such as antidiuretic hormones and arterial-neurotic factors which influence blood pressure as well. So we have three systems that actually regulate blood pressure. Firstly is the nervous system, where we have receptors in the vascular section and modulus which adjust pressure. And then we also have renin-angiotensin system which regulates blood pressure in the kidneys. Also we have hormones such as antidiuretic hormones and arterial hormones which reduce blood pressure. So let's look at hypertensive therapy, which means drugs that are used for controlling blood pressure. Now, in considering such, they are what we call the first-line drug therapy. First-line meaning these are the first drugs that you consider in any patient that has got high blood pressure or is high hypertension. So with such kind of drugs, you have first is the AC inhibitors. Basically, these are angiotensin 2. They inhibit angiotensin 2 receptors and alpha antagonists. They are antagonists, the angiotensin 2 receptor antagonists and alpha antagonists. Remember, these are two forms of receptors. We have alpha receptors and angiotensin 2 receptors. And what these drugs do, AC inhibitors, once they bind to these receptors, basically they block these receptors from function. And in doing so, they prevent hypertension. Then there's beta blockers. Beta blockers, they block beta receptors. We have calcium channel blockers, diuretics, and lastly, endothelial receptor antagonists. We'll look at these in more detail. This diagram is so small and thin, I can hardly read, so I'll skip it, but you can read it at home. Let's look at the alpha antagonists. And alpha antagonists, basically, they block the alpha 1 receptors on arterioles and venules. These are small arteries and small veins. By doing so, they lower the systemic vascular resistance on these arteries and thus reduce the hypertension. There are common adverse effects when using alpha antagonists. For example, the postural hypertension, meaning there's a risk of lower high blood pressure or lower blood pressure. Hypo means low blood pressure. Nasal congestion. The patient may experience nasal congestion. Also, pupil constriction and fatigue. So these are some of the adverse effects in patients that are taking such drugs. So be careful and be observant to such kind of effects. And then also, the first dose hypertension is common. Meaning the first dose that you give to a patient may experience a reduced blood pressure. Yes. And then alpha beta blockers, so to say. These beta blockers basically, they act by blocking beta receptors and angiotensin 2 formation and aldosterone secretion is decreased. So by blocking these receptors, angiotensin 2 formation and aldosterone secretion is decreased. Okay, I'm not going to go into details about what these are, but these are important chemicals within the blood that actually regulate the blood flow. It takes 1 to 2 weeks to be effective, and blockade of beta receptors can cause bronchoconstriction in susceptible patients, meaning that such kind of blocking receptors, beta receptors, may lead to certain patients having their airways within the lungs blocked, constriction. They'll be stiff and then will have problems with the breathing. They'll be wheezing and probably they'll have difficulties in such kind of matter. So the adverse effects with these drugs, firstly, is by it may cause insomnia. Insomnia meaning that some of the patients may not sleep once they take such drugs. Also, the patients may experience vivid dreams that are extreme. Okay, let's look at calcium channel antagonists. These are drugs that actually decrease the entry of calcium in the cells, and thus the availability of calcium within the heart and blood vessels. So they affect cardiac contractility, conduction, and vascular tone. Basically, the contraction, conduction, and the tone, the muscle tone of the heart affects it. Calcium actually increases the muscle tone. The more calcium you have in muscle cells, actually increases the muscle tone. Means it makes the muscles stiff. And when the muscles are stiff, you cannot contract easily, and that will affect the pumping of the blood. And there are common adverse effects to such drugs. Firstly is the hypertension, headache, and rash. Let's look at diuretics. The diuretics is basically they work by lowering blood pressure, by decreasing blood volume. So they suck water from the blood and reducing the blood volume. In so doing, they reduce the pressure on the arteries. And such kind of drugs, examples are thiazide diuretics and potassium sparing diuretics. Also, this can have mixed action. For example, indapamide inhibits reabsorption of sodium, water, and chloride. So it's important to be mindful of such kind of drugs. They will affect the reabsorption of sodium, water, and chloride ions. Okay, now let's look at basically the framework for strategies on how to combat cardiovascular diseases at population level, at general population level, or population-wide. You have population-wide strategies. The aim of such strategies must aim to prevent modifiable risk variables. They are modifiable risk variables. For example, feeding habits, eating well, exercising, and things like that. And then you also have at-risk individuals and groups. So, at such people who have risks, it's important to implement primary prevention. For example, address inequalities. There are inequalities which expose these people to such kind of or predispose people to CVDs. And you need to target modifiable risk factors. For example, stop smoking, stop eating junk food, etc. These people may be people, for example, who are obese, people are already smoking, and people, such kind of people must encourage them to stop such kind of habits. And also, when you get closer, there are CVD patients. Now, these you can see CVD patients, which means these are patients, these are people who have already contracted the disease. What should be the strategy? The strategy basically is to implement secondary prevention. There are drugs and surgery options that are available for such patients. The aim basically is to cure this acute care. They require acute care. So, within the CVD patients, you have one section of patients that have end stage condition. That means these are extreme death, near-death situations. The aim basically should be to prevent recurring of events and prevention of death. Let's look at lifestyle advice to reduce cardiovascular diseases. Firstly, it's important to advise patients to exercise at least 30 minutes per day. For example, walking for 30 minutes per day can prevent cardiovascular disease. Eating plenty of fruits, vegetables, and whole grain. Thirdly is to reduce intake of fats and sucrose, and also reduce weight. So it must be an effort for such patients to reduce weight. Stop smoking. smoking is one of the important factors that increase cardiovascular disease. Don't exceed moderate alcohol intake. For those who drink alcohol, drink moderate. Do not exceed the moderate intake. Also have a periodic medical checkup and take cardiovascular medication prescribed. So it's important to advise patients or people with old age, 60 to 70 years old, they must have medical checkup periodically. And if they are prescribed with medication, they must take those medications as prescribed. Anyway, that brings us to the end of this lecture. Here are references for this topic on atherosclerosis and heart diseases. I encourage you to read further so that you have more information. Thank you for listening, and bye.